Okay, no disclosures. Everybody here, 7 a.m. So, talk on whiplash. I don't know if everybody Googled whiplash. This is what would come up. Did everybody awake? So when you see this picture or video, what comes to mind? What do you think is going to happen?
Get a love tap in the back.
What's that?
Get a little love tap.
Love tap? Okay, that's good. So you're thinking she's in a car, whiplash.
Does she have a seatbelt?
This is awesome. Okay, no. So everyone knows that maybe there's going to be a whiplash situation. So this is probably the same thing that her dad knows. Right? So he's smart. He puts his crash test dummy suit on, buckles up. She doesn't like it very much and decides to get out, but he's safe for another day, right? So I thought it was funny. Maybe I should probably put the Whiplash song on a little bit longer. But in the 90s, there was, we didn't have the internet out really that much yet. You know, it didn't come out until the World Wide Web came out in 92. So it was easy to get volunteers to go do a crash test. So they actually at the San Diego Research Institute had volunteers. So they didn't know if they're going to get that many volunteers. They had over 600. And so this is a crash test. This is 6.6 miles per hour, okay? And just kind of watch what happens. I'll kind of stick to the side. But this is a 6.6 mile an hour crash. So they'll look at it here. You can see slow motion, kind of what happens. She has a head acceleration of 13.5 Gs. It's pretty good. And a 6 mile an hour, not much car damage. But they volunteered for this.
They got $50.
So they got $600. So, you know.
How many times?
And I don't know if that was per crash.
Okay, yeah.
But the point is a lot of times we see low speed accidents and we don't really think about too much of what they can go through. But this is a very interesting one. So this one's 4.8 miles per hour. This is the subject JH. So if your initials are JH in here, I don't know, then you're in trouble. Okay? Just a 4.8 miles per hour car accident. They actually had to push the car. Okay? Just to get the data. He volunteered, got his paycheck, and thought, hey, not that big of a deal. No damage to the car. But if you can see in slow-mo, got a little bit of a not too bad. Only 5 G on his neck. So the interesting point was he decided to do another one. That wasn't too bad. Let's just go to 7.8 miles per hour. And maybe he gets another $600. I don't know if he got one. But this one actually had to drive a little bit. And he got hit. Remember, this is 7.8 miles per hour. He's got all the sensors on. He's like, whoa, that was a little bit harder. 12.7 G on his head. Okay. One day I would like to meet this guy because he volunteered again. This time was 8.3, but they gave him opportunity to brace. Okay. So he knows it's going to come. And I like this picture right here when you can see him. He's about to brace. He's getting like, oh, I just had 2 of these. Okay. But not much car damage. So I get that question a lot in deposition. There wasn't that much damage, Dr. Lee. No, but that's why it's really important that today we look at, we know about whiplash, but what happens during that? Today we're going to focus on, there's so much, you can do a 3-hour lecture on this, but there can be some spinal damage, dislocation, ligament damage, okay? You can see in these small car accidents, okay? And then sometimes you can get some spinal cord compression damage, okay? I've showed this before. When you first look at it, it's a diagram of the spine, but no bones. okay? Just kind of take that into mind as you're thinking about this today, because we're going to focus a little bit on the ligaments today. Okay, so some of the anatomy, there's the alar and transverse ligaments. I don't have a picture of that, but it's going to be up in here. Okay, just to let you know, it comes off the odontoid. The other ones I have pictures of, thank goodness for Dr. Bowden. This is just some of the ligaments. You have the anterior longitudinal, the ligament flavum. They're back here, the anterior longitudinal. There's a posterior one right behind it. Okay, there's the capsule. So we saw that capsule in that one diagram. It's kind of like a saran wrap around that tissue. They're highly innervated. So remember with mechanoreceptors and nociceptors, mechanoreceptors are like if someone touches you behind, you know what's going on. Or if I move my arm up and down, I know where it's at. But if I was to take a knife to you, you're gonna know that and feel that, something especially behind. So those are the differences, but they are innervated. So what are some of the challenges in diagnosing ligamentous injury?
Not well visualized on most of our imaging.
Very good. I totally agree. What else?
Back to your picture that you showed, there's a lot of ligaments involved. So it's in the spine, it's not like there's, like in the knee, you can specifically look at the ACL, but in the spine, there's a ton of ligaments and capsules around joints and things.
Yes.
It's very complicated.
100%, of course. What else?
Hard to measure extent of damage when you have.
Yes. Yeah, it's especially when you have a lot of bobblehead and stuff going on. Okay, so hard to diagnose sometimes. You can see some of these symptoms. They'll come in, I got headaches, neck pain, some dizziness, and we just watch it and wait for it. Very difficult to see. So not really visible just on a plain radiograph. And standard MRI lacks resolution sometimes. They're in slices, if you remember. So it's not one continuous structure. So sometimes depending on where that slice is, you might miss a little bit of that detail. Okay, so here's a normal x-ray. This is somebody had a whiplash injury, very commonly taken, maybe a flexion extension x-ray. This is going to be read pretty much maybe a little bit of degeneration. Dr. Jackson's doing a biopsy this morning, so I'm mad at him. No, just kidding. But this is going to be read not too bad. Okay, you get a plain x-ray, they have these symptoms. We don't see anything, we don't see a fracture. So a lot of times the report will say a little bit of degeneration, and we take that report and go with it. Here's the MRI. All right, you got a T2 and a T1. So he was teaching me a lot, and he uses the acronym ABCDE. So when they read, they're really looking for the alignment. They're looking at the bone, any type of fracture maybe they can see. They're going to look at the cord. Is there any pathology in the cord, maybe from an accident, some trauma? D is going to be the disc. Got a little bit of bulging, maybe a little herniation here. And then everything else they're responsible for. And this is going to be read as not too bad, just a couple bulges, okay? But if you pan out a little bit, and why it's very difficult sometimes to see these ligaments, because if you pan out, looks like a bunch of stuff, but you can see a little bit of a sprained ligament right in that area. That's visual, and that's a good slice. Sometimes you can get above or below it and not really see it very well, okay? So consequences of the facet capsule injury. This is a little bit different. I just want to go here a little bit today. So arthrogenic reflex inhibition is very common in knees. This is where it really came from. I think I saw Todd walk in, or Carolyn. So when this happens, they're always worried about the muscles, right? And correct me if I'm wrong, okay? So you got this big knee joint, the capsule gets injured, and the central nervous system just grabs this. It's a reflex. It's gonna tell your muscles to chill, right? Because they don't want a lot of movement in there, because it's gotta try to heal. So for years, this has always been in the knees, and we have great data on it. But wait a minute, there's a lot of mechanoreceptors, and we have a lot of nociceptors in the knee, but there's a ton in the spine. Okay, per area, there's more in those ligaments than there is in the knee. Very important. So what happens is the central nervous sees this and says, I got to relax the muscles. So what muscles around the spine would it relax? Multifidi, paraspinals, okay? So when this happens, we're going to get a weakened motor control. Now, this isn't a low speed case, we saw those. What if there's traumatic brain injury with it? And you're going to see some of we have imaging for that now, really good specific imaging with DTI, and we can see the white matter very well and the pathways. But if that's inside a whiplash injury, because if you're getting 15 Gs, you can have a mild traumatic brain injury. So we have all the ligament structures, but that might be involved as well. So what happens is a consequence we call fatty infiltration. Okay, and we've talked about this. David spoke a few weeks ago, and we can see the multifidi. This is the lumbar region, but this is a direct result of arthrogenic reflex inhibition. That's something that we have not talked about. It's getting out there. More data in the spine is coming. But you can have, so if someone's in a 8-mile-an-hour car accident and they have a weakened neck already, what do you think the results are going to be, or symptoms? And that's a question I got deposed on one time. You know, they had all this pre-existing condition, Dr. Lee. I'm like, well, your client hit a weak neck. Not my fault. They were asymptomatic before. Here's all their structure. You may call it pre-existing. It's a weak neck. Okay? So there's data on that. So it's basically, you know, here's the grade 0. This is a multifidus muscle, very thick, really bad ribeye steak. Don't eat a steak today, I guess, or go watch the movie Alive, okay? So we can now evaluate this, at least ligaments, a little bit more precise. Spine Camp is medical metrics. They can embed it into x-rays. I know Reyes is using this now. But it's very accurate on just ligament pathology. So this is one that I started using, but it's very accurate on the AI. Okay, so you can see exactly per segment what's moving and what's laxed. Okay, so we take all this data, we take our exam findings, we take the history, we do all that, but we also can be able to objectify how bad that is. And this is very helpful. This is a patient, very young, 19-year-old patient that got hit as a pedestrian, okay? She was walking along, tried to cross the street, got hit by a car. They said she went just like 7 feet fall. Asked the sister, she was in the office. I go, where did she land? And she pointed to the light post. Now, this here, out to that light post, is not 10 feet. That's a long ways. She'd been struggling with this for a long time. Lots of headaches. You do your physical exam findings, and we know there's a ligamentous problem. Okay? So what do? Well, we can diagnose it, send them over for pain management, do a block, say, do you get relief? Yes. It's one way of just trying to find out if that facet's in play or not. It will give us information. Now, on this, you can see where there's AOMSI guidelines in the AMA guidelines. We don't want a lot of translation. Just so you know, if you deal with impairment ratings, if someone loses an arm in a car accident, it's about 25% of your body. So they have this permanent impairment. If you're over 3.5, it's a permanent impairment. It's 25%, the cervical region. So just whiplash, if you lose your arm or you get this. Now this is a finding. There's ways to treat it, okay, to see how they do. but at least gives you some data with what you're dealing with. This also gives us data when we're dealing with somebody who has surgery. Okay, very similar. She's had a 4-level fusion, doing really well, has a little bit of tightness. She fell, worried about damaging her hardware. We put this in the computer. We can see it worked really well. It's not moving, but she has a little bit of something. So we're able to, where am I at? I isolated C3, so I saw the motion there. But actually, even the fusion, I can isolate C7. And there's a tiny bit we can see what's going on because we're always worried about that adjacent segment disease. And this is something that we can actually attack and get on top of before it has to become a problem. So we threw it into the computer. She has just a 0.2 millimeter, a little bit. Fusion's working great, but above we got some more motion. So we can really identify what's going on with this ligament pathology, okay? So who's heard this term before from a patient? I just got whiplash. You could be at a party. It's got some whiplash, not a big deal, just whiplash. There's that movie called Whiplash that came up here, but I didn't want to put that. I couldn't edit it out in time. If you've seen the movie about drummers. But this is not a specific and not a medical diagnosis. Can reflect anything, okay? Should be translated in more precise clinical diagnosis for documentation. So if you just say they got whiplash, that's a little bit different, okay? This is the actual term you should be using. Just remember, whiplash-associated disorders, okay? This describes the clinical spectrum of injuries and includes the soft tissue, the ligament sprains, the facet, trauma, but it's standardized by the Quebec Task Force, and they have that 0 to 4 grades, okay? So here's your grades. So if you just come in, they say, I'm no problems, we're doing good, great. 0, no complaints, you're 0. Neck pain, stiffness, or tenderness only, you got a 1. Neck symptoms with some musculoskeletal signs, decreased range of motion. You have to understand in the court system, we're dealing with 2 different animals here. You've got your Blue Cross Blue Shield commercial insurances. You also have your medical legal insurance. They follow similar paths. I've used the example, you've got an Android and an Apple. Now, whatever phone you use, you can pick which one you want. The whole idea is they're different. They work, but there is a different animal in that realm. Because what they're describing, they don't care. I mean, one of the biggest things I have a hard time with ordering an MRI is they want what to order an MRI? What symptoms? They want radicular symptoms, right? But they may have a ligament issue. If you put on there, they may have a ligament issue. It's denied. But you put a V code down and you're in a med legal case, makes total sense, right? I'm looking for any other connective tissue damage, okay? So just closing up a little bit here. What is a diagnosis? The whiplash may be a mechanism, but it's an event, okay? So remember that. Also, if you are in trauma, diagnosis codes are very critical, okay? And those have been deposed a lot. They can really crawl up your back real quick when they do this. S codes are trauma codes. So when we're all working together, this is something important that when an attorney, we happen to have one here today, but I won't single you out. But yeah. But it's really interesting is that it makes so much sense when we're all on the same page. This is a case that takes a lot of people to treat. And make sure you're using the right codes because it paints a picture. If someone's using chronic codes and someone's using acute codes, No one wants to be deposed going, well, this doctor says it's this and this is this. What do you think? Okay. So just remember that. Tell the story in your documentation. Tell the why, what happened. So, I'm not emotional in diagnosis codes. That's not the reason. Okay. I get emotional when we see patients that just get a whiplash and they start dealing with symptoms and they just go down the road and someone says, just whiplash. And then they start taking medications because they're hurting and no one can figure it out. And we miss some little things. And then they need a lot of other interventions and they're still in pain. This could be your neighbor. Who has 6 grown kids, couldn't handle the pain. Last kid just got married and she took her life. She's 57 years old. And talking to their husband, he was telling me her history. And he said, we only found a doctor one time that can truly understand her symptoms because he was having to have surgery. And I don't think we need to have surgery to understand our patient's issues. Okay? But they're real. Ligament tissue gets protective. And other symptoms will happen with it. Tightness. And radicular symptoms or referred symptoms. Just make sure that when we're diagnosing these patients that they know that we understand them. Now, treatment-wise, there's lots of treatment. There's great, when we work together, it's awesome. The physical therapists I work with, and many of you, it's a great thing to work with as a team. As a chiro, certain things that we do, we have instrumentation that when we diagnose and use all these x-rays, I can come in on specific vertebrae with instrumentation and just move to make sure that capsule is freed up, because when it's under stress, the muscles are going to tighten down. There's biologics that are really good for ligaments. Dr. Campbell does a lot. There's PRP, there's other allografts that are very promising in this field, and they can help. It's not just burning nerves. They come into a play sometimes. So when we work with pain management, we talk to them a lot with this approach. But anyway, sorry, I did not know I was going to get emotional, but thanks. Okay.